So gonna go ahead and get started. It's a little bit about almost 10 minutes past start time. I expected a super low turnout. Judging by LinkedIn, this was a topic that everybody was interested in or that they hadn't heard about before to know that they were interested in it. So I just wanted to kind of throw this out there. I figured for me, having a smaller platform will help kind of make sure I am hitting on what everybody's interested in, that kind of thing. So part of the reason why I wanted to do this so close is just to make sure that I don't have an overwhelming amount of people with different levels of knowledge and interest and things like that. It is about 3 days after Christmas, so obviously today was a low attendance. What I want to do with this, just as everybody watches this, it's going to be a little bit different from normal journal club, and that I have chosen an article that arguably looks really good on skimming, has really good information, but isn't best written, I felt like. But I wanted to go through this more as like a teaching opportunity than like an evaluation of like research and stuff like that, like we usually do in Journal Club. I'm also gonna make this available to everybody who registered, but also just available on my YouTube, and I'll probably throw it up on Instagram and in the emails and everything like that, just because I feel like this is something that is not well known among dietitians and therapists and, you know, other healthcare, mental health care practitioners and things like that. So let me know if there is anything after you watch this, a particular metabolic change or other topic. If there's anything in particular that you were having more questions about, that you want to discuss in more detail and things like that. And do just keep in mind that this is meant to be a kind of a very broad overview. As I took notes on this, I intended this for a dietitian audience, but I also didn't want to keep it like super high level. I wanted it to be relatively accessible to somebody that is not a dietitian to kind of understand and go through it as well. But let me know if I did not achieve that goal, and we can always either sit down on a call or I can adjust and re-record for a different audience, you know, things like that. So just, I want this to be as helpful as possible and be able to provide a baseline in how you interact with your clients, but also maybe in how you assert your importance in certain situations or settings or, you know, facilities and things like that. So what I did, and I generally come to these with some type of thing that I wrote down, just honestly, just to keep my brain straight, but just so everybody can kind of see and visualize what I'm talking about. I'm going to close that. Let's see here. So essentially, here is my Google document, and I'm going to share this with everybody. I thought before we actually got into the article itself that it would be helpful to have definitions for certain terms. So I wanted to throw those first, and we'll go through them pretty quickly because, again, you're going to have this and I don't want to just like read stuff to you, right? So when we're talking about different things within mental health and trauma in particular, we try to make a distinction between a traumatic event and the actual trauma. So traumatic event is any disturbing experience, and that can be a wide range. Some places do specify that the event has to be life-threatening. I don't see that in most definitions of a traumatic event, but again, some of it does have to put a lot of fear, a lot of stress, intense feelings, or cause intense feelings in the individual to be considered a traumatic event. And there's some examples. Abuse is a big obvious one. Living with someone with mental health or substance use disorders. Violence is another really big obvious one. Racism, oppression, discrimination. And that's across all marginalized groups, not just a particular race or group of people. And then poverty. So my intake paperwork actually does ask if there is any history currently or like even as a child of food insecurity, because that is a trauma. And I find that my clients that have experienced that generally do better when they have a therapist on board with all of this as well. The statistics from this website where I got this definition is that 62% of adults have at least one adverse childhood experience, and 25% of adults have at least 3. And then that is distinguished from trauma, which is the long-term effects that happen after the traumatic event. It appears differently among different people, and whether there is trauma in those individuals is different, right? So even siblings living in the same, you know, say chaotic or abusive situation, one may develop like a PTSD or some type of trauma and the other one may not. But you can see in general symptoms of trauma in general. Remember, this isn't necessarily specific PTSD, but in trauma in general, we can see anxiety and poor mood, flashbacks, dissociation, hypervigilance, avoidance, and more. This dissociation, I think a lot of us kind of think of dissociation as like a blanket, like checking out or just not existing within our environment, which is true, but it doesn't always appear super blatant. So just kind of keep that in mind. You may not recognize a dissociation, especially a person that you don't know very well. So just kind of keep some of those things in mind as you're talking to your clients and as we're going through these. So trauma can lead to a variety of diagnoses, not just PTSD. And so you can see some of those listed there. PTSD is by far the one that I see the most common. Acute stress disorders, essentially, granted, a therapist would, or a psychiatrist would obviously correct me on this, but it's just something that happens more in a short-term period afterwards rather than a longer-term period. And then this brings the question we talk about a lot is trauma-informed care, and what is trauma-informed care? If you click on that link in this, in these notes right here, they have a nice little graphic and description that's actually a trauma-informed care kind of advocacy group, information group, if you want to say. And so essentially, rather than coming at an individual with what's wrong with you, what symptoms are you having, how are you reacting, what are you doing wrong, those kind of things, we're asking what happened to you. So we do this in a manner of ways, and it can get very hairy and very, what's the word I'm looking for? It can be easy to feel like you are discussing and talking with a client in a trauma-informed way and not be, right? So a lot of that is acknowledging your biases, trying to figure out and work through those biases, right? So like with dietitians, a lot of times that could be weight stigma, but that could even be more nefarious as far as like, do you have any like anti-LGBTQ feelings? Do you have any kind of racism or kind of knee-jerk reaction to any group of people, right? Not just one race or whatever. And so learning if you have those biases, learning that you have them, and then taking steps to correct them, right? So that's where like DEI training and things like that can come into place. That's not the basis of this meeting, so to speak, today, so we're not going to go a whole lot into that. But essentially, you're working towards building an environment that you and your client feel safe, right? And so a lot of times trauma-informed care is not effective because the administration, the systems in place do not support that, right? So do know that there are limits to how much you can really be fostering safety when you're not feeling safe or supported with your facility that you're working with as well. So it does look like you're building and maintaining trust with your client or your patient. Peer support is, this website was talking about kind of like group therapy settings where individuals that have experienced the same event or symptoms or whatever kind of is being discussed here, that they can discuss how they've shared their experiences, how they responded, things like that. But I like to think of peer support also being something that the practitioner needs as well. Collaboration in between the client and the counselor. So not like, I think you should do this, but like, how can I help you? They are in charge, right? Not the clinician. And then empowerment. If the client does not have a solid belief in being able to heal or have hope that they can improve, we need to hold that for them, that they can heal, but there is some resilience and things like that. And so just kind of a lot of different things to think about. There's a lot that goes into trauma-informed care. I would kind of argue that maybe perfect trauma-informed care doesn't exist because perfect people practicing it don't exist, right? So just it's a work in progress, and a lot of trauma-informed care is acknowledging when you make a misstep with your individuals. So moving on from that, like I said, I wasn't really sure where everybody was as far as what you have read or were interested in and have learned and things like that. So if some of this is really lower level for you, I apologize, but someone else may really need these things. And also at some point I stopped putting it in the definition and started putting it like as I was going through the article. So again, this isn't a super organized resource. It was just my thoughts as I was working on all of this. So the sympathetic nervous system, this is part of the autonomic nervous system that is responsible for that fight or flight, that knee-jerk response. Individuals that have like learned a little bit about like polyvagal theory may be aware of the sympathetic nervous system. But when this is activated, the individual is essentially going to be experiencing adrenaline rush, right? High heart rate, high respiratory rate. They're super alert. Their blood flow is really high, so you might see redness, sweating, things like that. They're going to have this glucose release, right? Essentially, so that glucose is in the bloodstream ready to go rather than in storage that has to be released, right? So it's just released right away, so it's there when you need it. And this skin conductance is an interesting thing to me. It's related to that sweating and the increased blood flow, but you can actually measure this and evaluate how much the sympathetic nervous system is activated, which I think is kind of cool. But you also have this give and take, right? So you have this increased alertness and you're like, you're ready to fight, you're ready to run away, that kind of thing. But the take part of that is that your GI function is lower. A lot of times people will experience a lot of like nausea, loss of bladder and bowel control can happen. Obviously, people have heard of that. And then salivation, which is really kind of an extension of reduced GI function, right? So this can all be important and helpful in situations where we're being chased by a bear or lion. I know that's always like the classic kind of almost cliche example right now, but when somebody is living in this heightened state where this sympathetic nervous system is getting activated more than normal for some reason, that's going to have long-term effects. So you can think of the strong link between like mental health and gut health, right? And that kind of bidirectional pathway that we see along the vagus nerve. So long-term, obviously, this can cause a major problem. In the short term, quick adrenaline rush, you got scared because you thought you were going to get into a wreck, calm down, move on. You're not going to see any long-term effects from that, like reduction in GI function. But again, the repetition happening is where you're going to see some problems. So the opposite, so to speak, of the sympathetic nervous system is the parasympathetic nervous system. This is where we want to be as much as possible. And so this system is going to be that rest and digest, that calming, that's going to bring us back to where we quote unquote should be at rest, right? So in this situation, our metabolism is working normally, right? So we are using our food and the nutrients and energy that we get in a way that is beneficial to our entire being and our bodies. We're digesting food normally, we're feeling good, we're feeling calm and relaxed. So we need both of these kind of to work normally, right? One not to be overactivated, one not to be underactivated, and to get to like that balance and still be responding to life, right? And then this HPA axis, which I feel like is kind of getting talked about sometimes in a lot of inappropriate ways, but this is just another stress response system, although calling it that may not be 100% accurate either. It's essentially the communication between the hypothalamus, the pituitary gland, and the adrenal gland, and some of that communication is in a direct response to a stressor. Hopefully that made sense. So moving forward, I've got everything kind of set up based on how the article was laid out. I will say, I think I said already that I didn't love the writing quality on this. Not that they necessarily said anything bad, but sometimes it felt like they were intentionally using bigger words than they needed to, or that they there were times in one sentence they use like 4 words to describe one concept, and they did it different ways, like 2 different ways in one sentence, right? And so it took a lot of like going back, wait, what did that say? Reading. So like I said, hopefully if you actually downloaded the article that I sent out for registration, you can see on there that it does say that this is like a preliminary, that it still has to be edited and stuff like that. So hopefully some of that gets cleaned up in the final draft, which I did not find. I also didn't spend a lot of time looking for it either, to be fair. That to say, if you had a hard time reading it, some of it's the quality of the writing in here as well. And so what I actually did with all of these, not with the abstract because it was just an abstract, but I actually went through, jotted down my notes as I was reading the thing, went through, if I found something that was like really confusing to me, like it didn't sound right, or like, what the heck is this saying? Like I would go off and research it, trying to find another article or another resource or something like that to clarify. And then after I had my thoughts down, I put the section into ChatGPT and asked it to explain it to a sophomore biology major, just because it felt like not a 5-year-old, somebody with some education, but not too higher level, right? It was my thought. And then I took from that pieces, and if I felt like I didn't agree with what ChatGPT was saying, I went and did some more research and then pushed back, and then kind of blended everything into a way that felt like it was cohesive and explained well. And then I compared again the section of the article I was looking at to what I have written down there to make sure that it's still aligned as much as I could make it align. Hopefully that makes sense, but I just wanted y'all to kind of get my thought into the process here, because I did have a hard time reading certain aspects of this. And it was a while. I was like, why can I not understand this? It was probably about the 3rd section that I was like, okay, it's just, some of it's just bad writing. Some of it maybe I don't know enough about certain things and I still have learning to do on my own, but some of it was just like, I read that 3 times and did not get the same interpretation of that sentence each time. And so it may be my brain not functioning normally, but I do feel like in part, at least, it could have been written in a better way. I've said that a million times, I guess we need to move on. So in the abstract, the one major thing that I really got out of that is that there are underlying alterations in sympathetic nervous system, endocrine systems, and metabolism that's associated with PTSD. In particular, that's what this one was looking at. And some of those present the same way as metabolic disorder, or metabolic syndrome is what they're talking about in here. But then they do talk a little bit about obesity, which there was nothing blatantly in this article that 100% had to do with weight and BMI versus behaviors, which is something that we harp on a lot when we're talking about different things and talking about trauma-informed care, right? And so I kind of try to put that into perspective as I go through when they do talk about obesity. And then, really what they're talking about, diabetes and metabolic syndrome. It was the gist of it here. So what we really want to, if nothing else, PTSD is described as a impaired fear inhibition, but that's not all that is happening, right? So that is an outcome of all of the things that have happened, but there are other things involved, and some of these we can have some influence on. I feel like this article does a really nice job of explaining metabolism in a way that a dietitian can then use to say, hey, we learn about metabolism and metabolic disorders, and we know these things, and we can work within them, right? And we can help influence these things, if that makes sense. So with the introduction, obviously also very brief, and the big thing that I took away from this is that 70% of people will experience a traumatic event throughout their life. And of those people, 10 to 20% will develop PTSD. So again, this is not necessarily anybody that undergoes this event is going to have PTSD. Not every soldier that comes home develops PTSD, right? And so why essentially is what we're looking at. And it looks like they are feeling like certain metabolic genetic expression or physiology within individuals may make certain people more prone to developing PTSD, right? This article, I don't know why I felt like I needed to put this right here, but it's older than general. So usually with Journal Club, I try to do things within 5 years so you can use them as ACE. You won't be able to do that with this one because it is older than 5 years old, but I do think it's a nice kind of overview, and that we can, use this as a jumping point for further conversation and either further articles for Journal Club or like whatever we're going to end up doing with this. And then I think another repeat almost of before, but we see these alterations in these different pathways and systems in metabolic syndrome. And then we're also seeing them described in PTSD, which is a simplified way of putting that, but it's introduction and we can move on with that, right? So the first thing I did want to say within this, I've actually presented on inflammation and depression and anxiety, and I had the same kind of gripe with it. As when you're reading research, they act like all of these different systems are completely separate. And so like maybe this person has an HPA axis activation and this person over here is actually having a sympathetic nervous system and the activation. And then maybe someone over here has inflammation and stuff like that. And like the truth is all these things work all the time, or work in tangent, I should say. They're all existing. And so it's maybe easier to conceptualize things individually, but we do have to know that they interact. And so you'll see this cytokines. If you're not familiar with cytokines, I'll go over them in a second. Those things pop up kind of around and in general in different ways throughout that. And it's because these things are happening at the same time, not individually, like not one or the other or one then the other. It's all kind of happening together. So especially for people that are not dietitians and aren't as familiar with metabolic hormones and stuff like that, I wanted to point out that we generally have a pretty poor misunderstanding in the general public of what cortisol is, right? We hear so much about it that we think it's a negative thing. So cortisol is essentially, it's a glucocorticoid, and like any other glucocorticoid, it is meant to reduce inflammation. So you get stressed, you get some inflammation going, cortisol pops up, it reduces that inflammation, and then we go back to normal. That's what's supposed to happen. But if somebody is chronically stressed, like, our lives, right? Or a PTSD situation, or they are continuing to live in a situation that is high stress, this remains high. So in a similar way that you can develop insulin resistance from having to chronically kick out more insulin, you can develop a resistance to cortisol as well. And that's when some of these things start getting problematic, so to speak, right? So as this resistance or lack of response, however you want to think of that, continues to happen, we see increasing systemic inflammation, and then the body is failing to respond. So it's like this cycle that keeps going and going. It gets worse, but then it can't cool, and then it gets worse, and then, like everything, all these distress signals lead to more distress signals when that kind of calming factor doesn't get put back in there. Hopefully that makes sense. I have a hard time, like in my head it makes sense, but sometimes I feel like I have a hard time expressing that outwardly to other people. So just let me know if that explanation wasn't super clear. But trying to go over this and continue, and hopefully as I continue to talk, things might start kind of clicking in place if they aren't yet. So HPA acts as activation. What is supposed to happen is you get these inflammatory cytokines and the body detects those. So we have these cytokines that are cytokines are messengers, right? Some are inflammatory, some of them are anti-inflammatory. So the ones that we don't like, quote unquote, they have their purpose. So I don't like to say we don't like them, but the ones that are kicking all of these activations off is inflammatory cytokines. So those are going to be, you'll see them listed lower if you get curious later, but the interleukin 6, 1 beta, TNF alpha, tumor necrosis factor alpha, so a lot of different ones around there. They signal inflammation, which causes this cortisol to be released by the adrenal glands. And then once that cortisol is detected without that inflammation, then the cortisol gets suppressed. And so essentially increased levels of cortisol kickstarts a negative feedback loop to limit it so it goes back down. If that GR, I'm drawing a blank on what that stands for now, I'm sorry, but glucocorticoid receptor, I believe it is, or something along those lines. If that signaling in that receptor is impaired, then that cortisol is not doing its job. So there's all kinds of pieces that go into place with this. So I really ran or struggled with the idea of like how simplified, like what to leave out to simplify versus what I'm doing to make leaving out and making confusing. So bear with me on that and ask for clarification if you have any or need any, I should say. But basically, with this signaling and these receptors being impaired, we have persistent inflammation instead of kind of this response and then recession of it, which leaves this HPA axis to continue to be activated instead of going back down to normal. And then sometimes higher and higher and higher cortisol release. And that's where we start getting all these negative things people talk about when they think of cortisol. So I tried to put this in a different way, same thing, but in a way that is maybe presented a little differently. So normally we have our bad thing, we have inflammation, our cytokines go say, hey, there's inflammation, that releases cortisol. Cortisol reduces the messaging of the cytokines, and then that cortisol hits that feedback loop and it goes back down to normal levels. That's what's supposed to happen. We are managing stress normally. Our boss gets really, really mad, and now we're stressed, and then like all this cycle happens, and then we're back down. That's what's supposed to happen. And so there's a couple of different ways that this can be abnormal. In metabolic syndrome, and this was my understanding when I was doing a bunch of research on depression and anxiety as well, is that we start the same. Bad thing happens, and I'm using that in quotes and kind of, facetiously, but, bad thing happens. Cytokines go on alert again. We release that cortisol, but now that cortisol does not inhibit the messaging of those cytokines in the way that it's supposed to. So our cortisol goes up, but the cytokines are still off running their mouth, so to speak, putting out the stress signal, something's wrong, something's wrong. And then that makes us release more cortisol, which again doesn't work. And so we get this loop, and then we have this persistent inflammation kind of triggers going on within the body. In PTSD, it's different. And so we have bad thing happen. And this isn't necessarily the initial traumatic event. This is something else stressed them out. They were out in public and got scared, or they had a flashback or something like that. So this isn't somebody that already has PTSD, I guess is a better way to say that. They have this bad thing happen, this quote unquote bad thing, and then they have the concurrent inflammation that goes with it. But instead of releasing a bunch of cortisol and not responding, we don't release enough cortisol. And then after we don't release enough cortisol, that feedback loop is also activated more rapidly. So we have less response and an early and more exaggerated response to bring that cortisol back down, which sounds opposite, right? And they do address that in the paper. And so the result is the same in that we don't have enough, sorry, let me rephrase that. The result in this situation, in this PTSD, is that we don't have enough cortisol exposure throughout our system to inhibit those cytokines, right? So the result is that we have this persistent systemic inflammation. And whether or not that matters right now, I don't think we have enough information, right? The result between the two abnormal pathways is still that those cytokines are going nuts and giving distress signals without any kind of regulation, right? So outcome, what we're seeing may be the same, and it's different pathways. Hopefully that makes sense a little bit. We do need to remember that cortisol and these glucocorticoids will raise glucose. So you think of somebody on like prednisone. And so we do see those higher levels of insulin kind of higher levels of glucose systemically, but then when we are activated and releasing glucose, it can go even higher. And then again, I know I said this already, but HPA axis activation and cortisol are normal. We are supposed to have these responses. So the response isn't bad. It's, when that thing gets interrupted and it doesn't work appropriately. My interpretation of this section is that individuals with PTSD have an opposite reaction in HPA axis activation than in other chronic stress situations. So like our lives, right? High cortisol with a reduced negative feedback is what we think of as chronic stress. And these individuals have lower cortisol with that stronger negative feedback loop. I know I'm saying these multiple times, but that's slightly intentional. Essentially in PTSD, cortisol signaling is insufficient. And then metabolic syndrome, it's there, but it's not working, right? So we don't have enough or it's not working. One of the two. So I feel like I've said that 40 different ways and we can move on now. What the authors are asserting is that they think over time, depending on genetic variations and in frequency of repetition of this activation, that eventually somebody with PTSD will shift towards a pattern seen in metabolic syndrome. So longer term, these individuals may actually have that more metabolic syndrome dysfunction or dysregulation. But I don't think we have a lot of research. No, let me rephrase that. We don't have a lot of research to support all of this. A lot of this is theoretical, or we have pieces of it that we know, but the whole how everything fits together is murky. There's a lot left to learn about this stuff, which is also why sometimes it feels very confusing, right? So the second system it talked about was the sympathetic nervous system. PTSD, we see this increased sympathetic tone, which basically just means the sympathetic nervous system gets activated more frequently and to a larger scale, right? If you're not familiar with heart rate variability, this is essentially, we think of it a lot as a marker of like just health in general, but mental health conditions do reduce this heart rate variability. And a lot of that is either that we are that we're usually at the state of activation, so our heart rate stays a little bit more rapid, right? And so what we should be seeing in a normal, healthy, kind of well-regulated individual is that the space in between our heartbeats has some variability, right? It speeds up, it slows down, that's normal, and we want that variability. We shouldn't be having the same consistent, we're not a metronome. And so if these individuals have this reduced heart rate variability, that does indicate a dysregulated autonomic nervous system, including the overreaction of the sympathetic nervous system and the underreaction of the parasympathetic nervous system. These individuals with PTSD, they do have higher levels of central and peripheral norepinephrine at baseline, and a greater release of this when they're stressed. So if y'all remember some of this stuff, these catecholamines, these are involved in that fight or flight. That's what gets you up and amped, right? So we are normally at a baseline, at our most relaxed, higher amped than an individual that is well regulated. So our norepinephrine levels are higher. And then when we get stressed, we have more release of that than the well-regulated person. So we start higher and then go even higher. So hopefully that helps a little bit. This seems to be related to reduced transporter and receptor activity throughout the body. So it's not that the sympathetic nervous system is just kind of going crazy and like calling in all the troops too early. It's that we don't have the response to it, like it doesn't transport out throughout the system as well, and the receptors don't recognize it as high, so it's like a constant kind of increasingly larger amount, if that makes sense. We do see this same kind of concept with increased heart rate, reduced heart rate variability, and increased levels of norepinephrine in metabolic syndrome as well. So essentially what we're seeing in both cases is that these individuals will have an exaggerated excitatory phase with a less robust calming system. So we can get excited, stressed, anxious really, really quickly, and it takes us more or longer to calm down after that. To me, this could feel very validating in a situation. People often, with anxiety in general, will often say, it's not normal. There's no reason for me to be this anxious about it. Why can't I calm down like somebody else? And like, well, there's actual measurable reasons to show this person why they can't do it. They don't just suck. They aren't just unable to get over it the way someone else can, right? Like there is a reason, things that are going on in their body that is making this happen to them. I also want to be clear when I say that does not mean that there is nothing to be done about that, just that we need to do things to fix it. And so they talk a little bit about that later on. I don't want this to be fatalistic. Well, there's nothing I can do because my body does this. There's things that we can do to improve all of this. Central fat accumulation, so that Visceral fat is specifically associated with higher norepinephrine levels and heart rate, but not fat that's underneath the skin. And so I really like this. I think we get kind of taught at the basic level that fat tissue is just storage, energy storage, and we really need to move into more of this, no, that tissue is actually an organ and it does things. It is active in endocrine regulation. It does hold on to hormones and release them in different ways. It is doing stuff, not just sitting there waiting for it to be used. So just kind of keeping in mind that kind of stuff as well as we move through all of this. So in addition to the initial stressor, some metabolic hormone resistance, particularly insulin and leptin, seems to influence that early activation. So if we've got metabolic problems going on, not related to PTSD, quote unquote, that is going to influence that early activation. So can make you more prone because we have this. And then we're also, again, learning that because it seems to be a problem with the receptors and the distribution of these catecholamines, does indicate that this is a baseline physiology, not just something that it happens as an adaptation to PTSD, if that makes sense. All things, again, that can be worked with, but that we need to really just try to leave at the door that this is like, well, if you would just exercise more, it would be perfect. Or, if you had just done this after your event, like whatever things people say to each other or themselves, right? To me, the sympathetic nervous system is a little bit more straightforward, so I didn't write quite as much in there, but if there is a problem with that, then just let me know. And again, this is meant to be kind of a very basic overview, not a complete comprehensive picture of what is going on. And then so moving into metabolic hormones, the big ones that we think about with metabolic syndrome is obviously insulin is a big one. And then we talk about leptin. This article I felt like could have done better and that they could have also included ghrelin in here. And I forgot until literally I'm going over this right now that I meant to go actually find some sources on the ghrelin impact and all of this. And then I just forgot. So we will not be talking about that today. Leptin does play a bigger influence, to be fair. And so we can have altered levels of leptin and neuropeptide Y in PTSD. This is a very, I was fixing to say poorly researched. It's not poorly researched, it's under-researched area of all of this. Generally speaking, we're seeing an increase in leptin and either an increase or decrease of the NPY based on PTSD or metabolic syndrome. But eventually we see, again, kind of this convergence. In this article, the ones that were discussed as far as systemically throughout the body was leptin. Remember, that's our fullness hormone at its that is such an underrepresentation of what leptin does, but we think of it as our fullness hormone. It acts on the hypothalamus. Again, these are all interacted, right? So it's acting on the HPA axis, right? The normal duties of leptin is to suppress appetite, and then it directs energy storage and moderates energy metabolism. So in PTSD, studies seem to indicate that we have an increase in leptin that may potentially be causing leptin resistance or be a result of leptin resistance, if that makes sense. So if you're not familiar with this idea of leptin resistance, essentially what we're seeing is that it leads to a dysregulation of appetite, and then we have an adaptive reduction in energy output. So these individuals feel hungry, but they're not utilizing their energy appropriately. This leptin is starting to store more than it should, if that makes sense. They do tend to gear more towards increased sugar cravings rather than just hunger in general. And then animal models indicate that when leptin is utilized appropriately, it helps squash the fear response. And when we have that resistance, we don't have that, even though we may have higher levels, we're not responding to it. So we don't have quite the ability to go, we actually don't need to be scared right now, if that makes sense. Neuropeptide Y is one that I don't think as many people are as familiar with, but it acts as a neurotransmitter, so similar to dopamine or serotonin, and a neuromodulator. It does all kinds of things. So you can see all of that there, but typically what we're seeing, or why we're talking about it in this, is that it is responsible for reducing anxiety and managing stress. It's distributed by the central nervous system, the hypothalamus again, and then the peripheral nervous system. We can increase NPY expression with protein or energy restriction, which in turn can make the individual hungrier. And it gets kind of hairy because okay, if it is increased, we can manage stress, then we should do energy restriction to help them manage their stress, right? Because that makes the NPY higher. It doesn't work that way. None of these things are as black and white and clear cut and straight line methods or processes as that sentence makes it sound. So in PTSD, we actually do see lower levels And so they do have lower stress resilience and higher anxiety at baseline, as expected by saying we have lower levels of that. In metabolic syndrome, we do have a higher level of MPY, but that increases food intake and fat storage, reducing energy utilization, which can also make them feel poor in some manner, a little sluggish, a little slow. Basically, like again, with that abdominal fat, that visceral fat in particular. So again, this isn't a case of more is better, less is worse. They do a lot of different things. So you just want to make sure that, we're not kind of giving off this impression that like, oh, energy restriction makes this go up, so just don't eat enough, right? Like that's going to backfire. It's also going to mess with your leptin levels, right? If you're not eating enough, and so then you have another or a more exaggerated problem that we had up there by doing that. So just, y'all are dietitians, make sure your client's eating enough. That's first. Insulin was discussed. In PTSD, insulin is mildly elevated, and it elevates more in response to carb take than in somebody without PTSD. So we do see insulin resistance related to PTSD with or without actual diabetes. That one wasn't really discussed very much in this, but just, throw it out there. So then they got to talking about hormone and metabolic changes in the brain itself, which this is not by any means my area of expertise as far as like what the different pieces of the brain do and stuff like that. So this, I did get some help with, good old Google to make sure I was like as clear as possible without having that expertise. But PET scans are showing that in PTSD, glucose metabolism changes, not always higher or lower. So we see reduced glucose metabolism, so there's less energy being spent in the regions of the brain that control executive function, memory, emotional processing, decision making, and then fear and stress regulation, right? And then we're seeing in higher activity in the part of the brain that is detecting threats, right? So we have maybe an overreactive threat detection. So things that normally don't feel threatening are feeling threatening, and then we can't downregulate that and go, oh, it's actually okay, right? As of right now, there is very, very, very limited research on the brain activity in metabolic syndrome in the areas of the brain that affect trauma response, if that makes sense. There is research on glucose metabolism in areas of the brain related to metabolic syndrome, but not in those specific areas, if that makes sense. So I just, again, I think we're talking more about trauma here, so I didn't really kind of go into all of that, but you can read the article a little bit more if you want. Additionally, when we're going through all of these, most PTSD research is done on soldiers. With reason, I'm not saying that's bad, but it's also leaving out a big portion of the population that does have PTSD. So they arguably are going to be better conditioned to have different muscle and fat stores that maybe we don't have in the general population. So we do have to keep that in mind, that not all PTSD research is applicable, or not all responses are the same in everybody that has PTSD. And then this BDNF, it gave it like one little sentence in here. I talk about BDNF a lot more in relation to depression and anxiety. But low rates of brain-derived neurotropic factor does seem to affect glucose metabolism when metabolic syndrome exists. We, as dietitians, can increase BDNF by increasing physical activity. EPA from fish oil can help. So there's some things that we can do with this, just kind of in our scope of practice. I didn't see any data here talking about BDNF and PTSD specifically. I would honestly expect it to be low, but I don't have proof of that. And then it moves on to inflammation, which I kind of wish they put this as a first discussion because everything kind of downregulates from there. But essentially, norepinephrine is stimulating the innate immune system, right? And so that is the source of the systemic inflammation. The norepinephrine goes, hey, stress. The immune system says I have to respond, inflammation. We can measure this by looking at levels of those cytokines, interleukin 6, TNF alpha. There's some other ones down there, interleukin 1 beta, interleukin 2. CRP is not really a cytokine, but it is an indicator, like a measurable indicator of inflammation. So that's that C-reactive protein. We see these elevated across the board: metabolic syndrome, depressive disorder, generalized anxiety disorder, bipolar, diabetes, and cardiovascular disease. You see these inflammatory markers, and it's the same ones, right? So I do often talk about that, and I'm not going to discuss it too much, but there is overlap here. Remember that from above when we were talking that norepinephrine is quicker to release and slower to downregulate. So we have a higher level of norepinephrine, then we have a baseline higher level of these cytokines, and those stay higher. So that's what we're looking at here. Interleukin-6 is one that seems to directly influence insulin resistance or cause supposedly insulin resistance. And they did this study. They were talking about in women with obesity, those that had an elevated level of interleukin-6 developed diabetes, and those that did not, that had normal levels did not, right? I put similar BMIs. To me, what we're saying is that the interleukin-6 was the factor, regardless of, you know, whether that BMI is quote unquote high or not. PTSD is associated with increased levels of interleukin-6, 1 beta, and 2. And those CRP levels are also increased. And the severity in which those are increased correlates to the severity of the PTSD symptoms, including that startle reflex. So that like involuntary, like panic, so to speak. Inflammation tends to reduce or appears to reduce the processing memory and the fear conditioning. We kind of mentioned that already. And then you can see kind of the different cytokines and like where they work. If I'm remembering 100%, this TNF alpha is more directly related to anxiety symptoms and not depression symptoms. And so that makes sense that you would see this in a PTSD situation, that those anxiety markers or those things that drive anxiety are higher. What is really cool, and sometimes it surprises some people, sometimes everybody in the room knows, but we do use beta blockers in anxiety management, right? And people always think of those as like heart medications, and they are, but you know, they do other things. So we do see ACE inhibitors and blockers reducing symptoms of PTSD because it reduces sympathetic activity. So it helps bring that activation threshold down. And it was kind of cool. I'd never heard this before, but there was research mentioned in here that showed that if somebody is involved in a traumatic event and they start them on ACE inhibitors, that they can actually reduce their risk of developing PTSD, which I thought was like really, really cool. It seems to be that these medications increase the loss of those memories. So I don't think they're ever going to go away, but they don't become quite so front and center in my brain. Outside of medications, other things that kind of lower levels of inflammation is CBT, cognitive behavioral therapy. I would assert that probably also other types of therapy, but that's where all the research is. Exercise, EPA, DHA intake, yoga, meditation, mindfulness, all of those things can help bring that down. So stress management, right? Let's see. So moving forward, the biggest takeaway from here, I think for most of us, and that we can use as talking points when we're interacting with like other healthcare professionals in our facility, is that PTSD is not just psychological. It is psychological, obviously, but it does have metabolic and physical components. If we are like insisting, as a lot of people do, that, you know, physical and mental health are separate, there it does have some physical health implications. And the metabolic disease is not just a lifestyle. A lot of these things are things that happen because the genetic coding is a little different. There's little SNPs and stuff that are different that code for activation of certain things in a different way. But metabolic syndrome and PTSD both involve chronic stress signaling, inflammation, differences in neuroendocrine release, and the bidirectional, so the brain and the body, that GI connection, right? That bidirectional connection. So again, I think that this is a really clear way of strengthening the rationale for including dietitians in psychiatric care. You know, somebody else may disagree with that, I don't know, but that's my take on it. Obviously I'm biased, right, as a dietitian. And then I did like a little bit of TDLR right here, which I'm not going to read to y'all because again, we don't need to repeat the same thing over and over again. So hopefully this helped kind of break things down. I know I talk very rapidly. Luckily, as a recording, you can go back and slow me down if you need to. But hopefully it gives everybody kind of a very basic overview of things that are going on in the body and got your wheels turning. I know I didn't really talk in this about like, okay, well, what do you do with your client when they're experiencing these things? But hopefully that at least got some of the wheels turning and kind of how you can talk to clients about how this all integrates. Again, let me know, please, if you have any questions, any thoughts, any clarification, or if you're like, nope, that did nothing, or no, it was too big, like whatever thoughts you have, give it to me so I can continue to refine and understand what everybody needs and wants and is hoping to get out of things and stuff like that. So again, I will see you next time. I haven't quite put together next month's because we are in a state of major upheaval right now. So I don't have everything kind of planned out right this second, but I will get this out as soon as I get all my ums and ahs and weird pauses and stuff like that edited out of here. And I hope to hear from y'all pretty soon. Thanks. Bye.